Good afternoon, everyone. My name is Alicia Rice. I'm the Training and Education Program Manager here at MaineHealth Center for Tobacco Independence. I'd like to welcome you to our ongoing webinar series. This is one component of our Tobacco Treatment and Prevention Education and Training Program, which is sponsored by and brought to you on behalf of the Maine Center for Disease Control and Prevention, Department of Health and Human Services. This webinar will be recorded and posted to our website following the event today. We are offering one continuing medical education credit and one CHES credit for this webinar, which will be sent to those who attend the entire session today. In order to claim CMEs, you must have a profile in Cloud CME. If you already do, you will find your credits in your profile within a week of this event. If you do not have a profile in Cloud CME, you can find the instructions on how to make a profile in the post-webinar email that will be sent out later today. For those that are collecting CHES credit, record of your attendance will be sent to NCHEC after the event. And only those who registered for the webinar, connected via the Zoom link, and attended the full session will be able to receive CMEs and CEUs, as we are required to verify those who attended. At the conclusion of today's webinar, an evaluation will appear on your screen, as well as be sent to you via email within 24 hours after the event. We do encourage you to take the time to provide your feedback. It's not only helpful to us in planning our webinar series, but also to our presenters as well. Today's webinar is titled Stepping Stones to Client-Centered Tobacco Treatment, a justice-involved community webinar, and is presented by Derek Bowen of MaineHealth. Derek has experience as a health educator specialist, facilitating evidence-based programs within the community, including the Freedom from Smoking program. Derek completed his bachelor's degree in community health education in December of 2020 at the University of Maine at Farmington and is currently pursuing the National Certificate in Tobacco Treatment Practice. Derek joined the CTI training and education team in July of 2023 as a tobacco treatment and prevention educator. And before we begin, just a couple of housekeeping items. All phone lines have been automatically muted to help reduce background noise. We do, however, want you to participate in this session. Please type any questions you may have during the presentation into the Q&A box, and we will address them as time allows at the end of the webinar today. For your convenience, a copy of this presentation will be sent out via email after the webinar. And as I mentioned, the webinar will be recorded and on our website. At this point, I would like to turn it over to Derek.
Perfect. Thank you, Alicia. And hello, everyone. Thank you for being here. And so, as Alicia mentioned, today's topic, of course, is talking about the justice involved community. And let's just take a look and jump right into our objectives today. But before we do that, just have a quick disclosure slide. And I do want to mention that references to tobacco in this presentation refer to the commercial tobacco use and not the sacred and traditional tobacco use by Indigenous communities. And so again, let's look at those objectives. So we're going to start by just introducing exactly what that justice system is and what we will be talking about today. I'll then present some national statistics and trends regarding tobacco use in the justice-involved community, discuss some tobacco disparities within that community, and then also identify struggles and challenges that they have to face during that treatment and recovery process. And we'll touch on a case study, share some recommended evidence-based tobacco treatments, and then end with suggesting some useful resources to aid in tobacco treatment and recovery. And so, starting right off with some definitions. Starting with justice involvement. this is essentially the act of an individual having contact or just some sort of interaction within the criminal justice system. This is primarily done through police, courts, or the correctional system interaction. Social justice, on the other hand, it becomes achieved when the population becomes aware and can develop their full potential with no constraints or artificial hierarchies. And then we have health equity, and this pertains to social justice with respect to health, which acknowledges the following ethical and human rights concerns. So first, we have that all people should be valued equally. Health has a particular value for individuals. We want non-discrimination and equality, and the rights to health and to a standard of living adequate for their health. And so moving forward, we're going to break these down just a little more piece by piece, starting with the justice system itself. And so here is just a very brief overview of what the justice system is. So as a whole, the justice system includes federal and state prisons, jails, community corrections, which includes probations and paroles, as well as court-ordered drug treatment, and then also juvenile corrections pertaining to the youth. So relating this concept to our training today, we're going to be focusing on tobacco treatment for this justice-involved community, which relates to anyone who has been or is currently involved within our jails, prisons, or courts. So notice how I mentioned courts, of course, because the justice-involved population also includes those involved with, child protective cases, drug courts, drug cases, etc. And so we are going to go over this more in depth in the later slides as well as do a breakdown of each piece of this and how it can create a long list of barriers and challenges when it comes to tobacco treatment. And as you'll see in later slides, it is a very needed issue to address within the justice involved population. So looking at these next few slides, we're going to be looking at some facts, some trends, some statistics for you all. And this is going to include, of course, some statistics, but I'm also going to introduce some tobacco use disparities and discuss those further on. And just one question, I just want you to all, you don't have to input your answers in the chat or just kind of do a self-reflection. So one question is just how many Americans do you think are currently involved within our justice system? So feel free to just take a moment to yourselves and think of an answer. Again, that question is how many Americans do you think are currently involved in our justice system? And here on this next slide, you'll see the answer. And that answer is 5.6 million Americans are currently within the justice system. And remember, that means jails, prisons, courts, or on probation or parole. And then of that 5.6 million, around 3 million of them are currently within either our jails or prisons, which is a very high number. And to put that into perspective, that 3 million, one of the highest populated cities in our country is Chicago. Chicago currently has a population of around 2.7 million. So imagine every single citizen that resides within Chicago is either in jail or prison, and then it still doesn't even amount to the amount of people that are currently in our jails or prisons. And so a very alarming number when you put it into that perspective. And so let's relate this to tobacco use now, starting with another question that I'll have for you all to just self-reflect on. And the question is, what percentage of individuals in the justice system also use a tobacco product? And so again, that big number, how many of them are using a tobacco product as well? And so looking at this next slide, around 50 to 80% of those involved in the justice involved population use a tobacco product. And so why is this range so large, right? 50 to 80%. Some may think of that as quite a large range. And really the answer is it can be very tricky when it comes to collecting data within the justice involved population because it's currently it's constantly changing rather. People are leaving and entering the justice system every single day, so it's really hard to get an exact number. But what they found over years and years of research and testing, it always falls within that 50 to 80% range. So regardless of how we look at it, over half of these individuals are going to be using a tobacco product as well. And, so of course that number will always fluctuate, but it's going to roughly stay within that range. And regardless of the number, it is a very high number of justice involved individuals also using a tobacco product. And this is concerning, and it makes tobacco product use a bigger threat in these justice system facilities. And, being involved in the justice system is a tobacco use disparity within itself. That's one of our disparities when it comes to tobacco use. However, many individuals have multiple tobacco use disparities, which increase the likelihood to participate in this action of using the tobacco product, and it decreases the likeliness to pursue treatment if you are already using the product. And focusing on health disparities and tobacco use disparities, let's look at some others that we have. And then on your screens, you are going to see some of the biggest health disparities when it comes to tobacco use. This is in no particular order, but we do have behavioral health, mental health, substance use, race or ethnicity, socioeconomic status, education, and sexual orientation. Throughout these next few slides, I'm going to be discussing a few of these further in detail. And just before we do that, we're going to take a quick look at some shared risk factors between smoking and justice involvement and why that's important. When it comes to shared risk factors, they occur in two main areas. The first being within community, society, and public policy. Things like structural racism, discrimination, tobacco industry specific target, and then also the numerous barriers to treatment. And of course, we'll get to that later. But all of the things combined that I just mentioned within our community, society, justice systems, and public policies, and each of these issues have proven to have an increased likeliness to use a tobacco product or other addictive substance. And they essentially attack this individual from two different levels. One side is the tobacco product itself, and then being involved in the justice system, of course. So kind of both of these areas are constantly, targeting these individuals. And we also have the individual personal level, which includes, again, the race, ethnicity, gender, income, education level, certain demographics, and previous justice involvement. Both of these combined will create so many additional risk factors for the individuals and make it very difficult to not cave in to use a tobacco product, to give up on their quit journey, to reuse that product again. As these risk factors all will increase stress levels, lower quality of life, and get you involved with many other individuals that are also in a similar bad situation. And, I talked about this on our last slide, but these shared risk factors lead to increased likelihood of negative life outcomes, like addictions, in this case, nicotine or tobacco products. And then, of course, we have those other harmful substances, incarceration, relapse, reincarceration, or just overall poor health and low quality of life. These shared risk factors impact so many different areas of one's life. It can be overwhelming to try and make a change or to get out of harm's way when it comes to these risk factors. And so, again, looking at some of these health disparities, starting with behavioral health. Behavioral health covers a very broad range of conditions, which include attention deficit hyperactivity disorder, or ADHD. We have ODD, conduct disorder, IED. I'm just going to go through these really quickly. DMDD, anxiety disorders, autism spectrum disorder, depression, bipolar disorder, other mood disorders. We have substance abuse, gambling, certain phobias and fears, as well as eating disorders. And as you can see, all of these conditions can result in an increased likelihood of using a tobacco product. And oftentimes, individuals can have multiple conditions on this list. Very common one you'll see is anxiety and depression combined, right? Certain patients, clients are going to have at least one of these disorders, if not multiple. And each one they have even further increases the likelihood that they're also going to be using a tobacco product. And that's kind of where that concern lies. Um, so looking at behavioral health further, how prevalent are the behavioral health conditions in the US? So let's take a look at that. It's found that 1 in 4 adults in the US are currently living with one of those listed behavioral health conditions. And as I mentioned, these individuals do have an increased likelihood of tobacco product use as well. So if we look at this at a different light, within the US, over 49 million individuals use a tobacco product, which is about 1 in every 5 people. Among that 49 million, 40% of them have been diagnosed with at least one behavioral health condition, which is around 19.6 million. And of course, the emphasis on what I just said was have been diagnosed. The number could be much higher, given that there are individuals that use a tobacco product who may have undiagnosed behavioral health conditions, one or more. Um, but even then, it goes to show that 2 in every 5 tobacco product users have at least one diagnosed behavioral health condition. And another alarming statistic here relating to behavioral health is that the tobacco products these individuals choose to use have a higher risk of death than the behavioral health condition itself. And smoking rates are especially high for people with mental health conditions. 1 out of every 3 adults with a mental health condition also use a tobacco product. And smoking rates are especially high for people with severe depression, PTSD, bipolar disorder, and schizophrenia. Up to 80% of people with schizophrenia use tobacco. And quitting is going to be very challenging, and rates are not going down, among this general along with the general population. And people with these major mental health issues are what we would call as someone as a heavy tobacco product user. And it's going to make it going to lead for them to be more difficult to successfully quit and substantially increases their health risk. So as you can see, there's a very strong link between tobacco use and the use of other substances. And people who use other substances are much more likely to participate in smoking a tobacco product. People who smoke are also much more likely to use other substances. And people with any substance use disorder use tobacco at rates 5 times higher than those without a substance use disorder. Tobacco users are 4 times more likely to have an alcohol use disorder, and right around 80 to 90% of people with alcohol use disorder are tobacco users. And up to 95% of people on methadone treatment also use a tobacco product. So you can see a lot of this is really intertwined and either increases the likelihood of this individual using a tobacco product, or it even makes them use it at a more severe, more alarming rate and become one of those heavier tobacco product users. And looking at this graph that I have for you all here, this represents another one of our health disparities being race and ethnicity within our prisons and jails. And if you look on the left side, it shows the percentage of this race in the U.S. population, and on the right is the percentage of these race or ethnicities that have been incarcerated. So as you can see, there's 2 data points for each race that we have listed. We have white, black, Latino, and native. And as you can see, the only 2 points that show a decline is from the white population, while the black, Latino, and native points all show an increase, the most severe one being the black population, right? We can see that increase is much more than the Latino or native populations. And this is essentially telling us that the white population is more underrepresented in our prisons and jails, while the black, Latino, and native people are all overrepresented. And this is just alarming because, we can see that we break it down, just looking at compared to the US population, 60% being the white, while only 38% of that 60% is incarcerated population. While if we look at the black community, again, it's that most significant increase. We are at 13% of the US population, all the way up to 38%, so equal to the white population being represented in our incarcerated populations. So just something to look at in a different perspective. We also have, I mentioned sexual orientation being another health disparity. And LGBTQ plus individuals experience disparities related to social stigma and discrimination. And they also have high rates of tobacco use. It is found that people that fall within this community smoke at twice the level of the straight community. Transgender youth have 4 times higher cigarette use and 3 times higher e-cigarette use. These groups are essentially targeted by the tobacco industry. Big Tobacco inspires brand loyalty through targeted advertising, marketing, and sponsorship of various LGBTQ plus events. Tobacco companies really target that, again, the LGBTQ plus community and the Black community to help promote menthol cigarettes, which are, more popular within these communities, but they're also highly addictive. And so going through after those health disparities, we're now going to be discussing the sequential intercept model, or SIM. So SIM is a model that describes how individuals with mental health and substance use disorders first come into contact and make their way through the justice system. And what this model shows us is the gaps, barriers, and challenges that these individuals have to face, which of course we'll discuss later on. And essentially the SIM is broken into 6 different intercepts, from going from intercept 0 all the way to 6. Intercept 0 is what we call community services, and that's what we have put in place, and they are essentially for anyone within the general public, as Intercept 0 happens in SIM before anyone gets incarcerated. So it's just those things that we have put in place for the general public. Community services, these would include crisis lines, crisis continuum care, things of that nature. And then we have intercepts 1 through 5. And these are as follows. So law enforcement, detention and hearing, jail and court, re-entry, and then lastly, community corrections. And so we're going to review each of these one slide at a time here. So starting with the initial law enforcement interaction. So essentially, maybe 911 gets called, or the individual gets into some form of altercation with local law enforcement. This typically involves diversion from law enforcement and other emergency service providers that respond to those with mental health and substance use disorders. This can allow people to be diverted to receive treatment rather than getting arrested or booked to jail. So as you can see, the first intercept is typically where some form of arrest occurs, and it essentially brings us to the next intercept, intercept 2, which is detention and hearing. This is that very initial detention that is, it's that very first court appearance. This is also in the time where the diversion occurs for community-based treatment, which is where our jail clinicians, social workers, and court officials get involved, and this happens during intake, booking, or the initial hearing. After these instances, this individual will enter Intercept 3, which is jail and court. So looking at this one, this intercept contains both jail and courts because, as we know, everyone's path has its differences. It can vary from person to person. And so after that initial booking and the first court appearance, this can lead to essentially two different outcomes. The first outcome being that that individual goes to jail, and then the second outcome is that individual has to attend a specialty court for further hearing. So if that is the case, if this person has to go to specialty court, that individual is entering this due to either high risk or high need circumstance. And the specialty court typically provides direct treatment and it's an alternative to incarceration. For those within this intercept that do get incarcerated, though, they initially begin in jail. Intercept 3 involves diversion to community-based services through jail or court processes and programs after a person has been booked into jail. This includes services that prevent the worsening of a person's illness during their stay in jail or prison. Dispositional court also falls within this intercept, which leads to that final determination of the case at hand, which can lead to staying in jail, possibly entering prison, which again is going to lead us into Intercept 4, which is reentry. And so, as I just mentioned, dispositional court occurs and it will result in either jail or prison time, which is classified as reentry. So during their time, these individuals receive supported re-entry back into the community after jail or prison to reduce further justice involved of people with mental and substance use disorders. And this involves re-entry coordinators, peer support staff, or community in reach to link people with proper mental health and substance use treatment services. And then this, of course, brings us into our final intercept, community corrections. And so once an individual has served their time, they enter this final intercept, which results in having either parole or probation for a designated time period. This all differs based on that specific case at hand and ruling from the court. It involves community-based criminal justice supervision with added supports for people with mental and substance use disorders to prevent violations or offenses that may result in another jail or prison stay. Once this has concluded, this individual is deemed ready to re-enter society and go on their own. Now, the question, of course, is why review all of this, right? And it shows the extensive process put in place for those with mental health or substance use disorders that get involved within the justice system. And as we discussed earlier, many tobacco product users fall within this category on some level. Not all of them, of course, right? There's still a large chunk of tobacco users that are incarcerated that don't fall within this category. And for those that may not fit this demographic, there's increased gaps and barriers to get sufficient and effective treatment, and making tobacco treatment very difficult during this high stress period of their lives. And it's deemed difficult for various reasons, and that's what we're going to get into next. So looking at common barriers to tobacco treatment within the justice system. Barriers are defined as an obstacle in the way, in some form to achieve a certain goal. Think of it as like an obstacle course race, right? In an ideal situation, if you're trying to get from point A to point B, it's just be able to run straight through and get to that end goal. However, as we know, when it comes to tobacco treatment, there's obstacle courses, there's things that are going to get in our way, and it makes getting to the end goal difficult. And with all these gaps and stressors and difficulties within the justice system, the more obstacles arise, and it makes it harder for these individuals to get from point A to point B. And so we're going to go over some of the most common barriers that we see in tobacco use treatment, and starting with implicit bias. And so implicit bias is essentially unconscious attitudes and bias towards the incarcerated population, especially really in those later stages of being released back into the community, back into the public after their prison or jail time. So this attitude and bias really drastically impacts these individuals' feelings, actions, and decision making. You may kind of relate this to stigma, which is very similar. And implicit bias can affect the individual in many different lights, finding a job, getting back on their feet, rebuilding relationships, and more. This sort of bias can drastically increase the stressors that they encounter in daily life, which can be a trigger to smoke or to use a tobacco product. Again, the higher the stress level, the more likely they are to fall back into that unhealthy behavior. And then the next one is the lack of behavioral health training or knowledge. And this is specifically talking about how the justice system staff and employees may just not know enough, or they haven't been trained about certain behavioral health conditions, or and this creates a great conflict for the incarcerated individuals. The staff also just might not, they might not get proper training on how to better help these specific populations due to, various reasons, one being budget or funding, which is another one that we're going to talk about in just a few slides. And again, this creates another gap in the relationship between the staff and the incarcerated population. Looking at centralization or decentralization, we're going to go over both of these. And this is essentially two contrasting organizational structures that creates essentially the decision-making process within organizations. So first being centralization. This is when decision-making is done kind of at the top, the big bosses, for lack of a better term. They make all the decisions. It's typically with just management and the people that are more involved, in this case, within the incarcerated population, don't really have any say in any of the decision making or processes that are happening within their work. And so decentralization is the opposite. This allows opportunity for decision making at numerous levels within the organization. It's more of an all voices are heard approach, or from the bottom up approach. This pertains to the justice system and tobacco treatment because centralization approach increases likelihood of missing important needs for the prison or jail, because these people aren't necessarily seeing what goes on a day-to-day basis within these facilities, where a decentralization approach would allow the more frontline workers to have their voices heard, and would increase the likelihood of things that, really need to be fixed actually being fixed, because they're able to put in their input, say, hey, this isn't working. This is our things that need to change, where centralization, that doesn't really happen. Um, Next one, again, as I mentioned earlier, is the budget. And jails and prisons have varying budgets. Most tend to have a more tight budget, and this, of course, can depend on location, state, etc. And so tobacco treatment and resource options may require funding, grants, or donations to even have a tobacco treatment program at all. Another one, just various missions. These are, happening at once, not really knowing where to start. And so, of course, we have other issues at hand, other substance use. We have tobacco use, violence, changing regulations and policies, getting, again, the appropriate staff, um, funding, budget, again, etc. And so it's hard to focus on one issue at a time within this particular environment when there's so many needs, and it's really a revolving landscape from day to day. You never really know what's going to be the high priority on any given day. And then the next one is proper access to the target audience. And so finding time, again, is something that allows the incarcerated individuals to participate in tobacco treatment efforts within the scheduled day. And so we have different things that kind of go into this too, is do they have the time within that scheduled day to add this tobacco treatment? Do they have enough of a audience to get involved in this tobacco treatment? And that's where really signups versus involuntary attendance come into play. Like, are people interested in this, or are they more being there because they have to be there? And of course, I can go into that next bullet point is the overall willingness to participate in treatment. So if it's more of an involuntary attendance, it's most likely that the overall willingness to participate is going to be quite low. Rather, if they're signing up because they want to be there. And so we're having this mix. It might be a little bit 50-50 in some places too, but low willingness to participate is going to make the tobacco treatment even more difficult for both the staff and those enrolled in the program. And then length of stay. Some individuals have to stay, serve their time. It's much longer than others. No one has the same sentence at the same exact time. And this can make a group effort, which most tobacco treatments in these types of facilities are. They're usually group rather than one-on-one, but it can make these group efforts challenging if, again, as I mentioned earlier, it's that constantly changing environment. People are coming and going on any given day. Um, and it can be hard to build a rapport with a group of people that, want to be there, want to quit their tobacco product, want to become healthier. And then, their time might leave, they go back out into the real world. You might get a few new people that aren't so willing. And so it can make this tobacco treatment process very, very difficult. And then again, I've touched on it a few times already, but involuntary participation. So forced participation can cause disengagement and insufficient treatment, which I'm sure we've all seen on some level before. And the prison and jail environment can already lead to these individuals feeling like they have a lack of control in their life or choice in their life. And so it could just be like, oh, another thing that they have to do today. And it's this could also be even when they leave prison or jail, and it could be a part of their probation or parole program. And they might just be doing this or showing up to these appointments again just to check it off the list to make it look like that, they're doing everything that they're supposed to do, but they might not actually be getting anything out of it. And again, insufficient follow-up care. Some individuals just get much better treatment while serving their time, but they do not get any treatment when they're back out in the community. And the reason for this could be the cost, lack of insurance, lack of transportation, whatever else. And, tobacco treatment, as we know, requires more of a long-term care when it comes to follow-up. And so the chances of success decreases without that follow-up care. So if they're getting that sufficient treatment when they're incarcerated in their prisons or jail time, but when they get out into the back into the world and they can't afford or they can't get to these appointments, they're not getting that follow-up care, and it's going to be very difficult for them to stay on that tobacco treatment progress that they were on. And so going through all of those, we're going to continue speaking on some barriers, but we're going to look at personal barriers to tobacco treatment. And so the first one that I have is health literacy. So now we're focusing on these incarcerated individuals specifically. And so health literacy, this essentially leads to either lower education or lower reading level, which can lead to low health literacy. And so health literacy, what that exactly is, it's the ability to understand, obtain, and read healthcare information, or knowing to make, what's a healthy lifestyle choice and what isn't a healthy lifestyle choice, or just ability to understand why is smoking unhealthy? Why is eating fast food every day unhealthy? It's having that ability to know what's healthy, what's unhealthy. And it's also the ability to be able to follow a treatment plan. So it covers all of those things. It's a big umbrella. And low health literacy increases the challenges of tobacco treatment in itself. Next is inaccurate beliefs, which also ties in with that health literacy. Some may not truly understand why smoking or using a tobacco product is unhealthy, and they might not understand what exactly it is doing to their body. And it's also common, especially within the justice involved population, that many believe that smokeless tobacco is fine. It doesn't bother them in any way. It's only smoking with cigarette that's unhealthy. And these beliefs can come from, again, low health literacy, can also come from your family, your loved ones, friends, whatever it may be, just being told that for years and years, because it's very possible that they could have had low health literacy as well. That's what they believed. So they taught you to, grow up to believe those things as well. And it's really hard to break that ingrained belief that you've had for years and years. The next one is mistrust of medical providers or professionals. And as you'll see, a lot of these kind of intertwine. This can deal with health literacy again, or past events with themselves or loved ones. It can also be a trauma response. A lot of these individuals might have a very hard time being able to trust others, especially in the medical environment. And so being unable to trust providers is, of course, going to make treatment ineffective. Now, I mentioned this one before as well, but no transportation can make treatment and healthcare very, very difficult, especially in more rural areas. And so if you're not living right in the city, and of course, as we know for those of you, I'm in Maine myself. So for those of you who are also in Maine, Maine's a pretty rural state, and there's other, of course, rural states. But I know I wouldn't be able to myself walk to appointments. And if that's the case for these individuals as well, it's going to make treatment almost impossible if they don't have that transportation. And then mentioned this one a little bit earlier as well, but the cost of care. So once finished, serving their time, these people do not have money. They don't have a job just yet. And oftentimes they lack that support system to help get them back on their feet. And so the cost of care after leaving jail or prison without insurance is, of course, very, very difficult to be able to afford, especially when payments, required up front at a lot of these places. So many may want to make a change. They want to have that healthy reset after they serve their time. They want to they want to turn their life around, but they simply just can't afford treatment to help make these changes. And then stigma and discrimination. Stigma itself, it's the act of society portraying a false claim to a specific population, typically in a negative way. Two of the highest stigmatized populations are people who use tobacco and people who have been incarcerated. So you combine those two of those most popular stigmatized populations, it's going to be very difficult for these people. And stigma and discrimination can lead to severe mental health issues, lower quality of life, and social isolation. Throughout all of these barriers, I'm sure that you can picture how hard it is to overcome many of these issues all at once, because most likely all of these individuals they're not just having one of these barriers, right? They're experiencing most, if not all of them. It's just leaving their prison or jail time, or even just dealing with the courts. It's one of the most stressful possible situation that's happening in these people's lives. It's not an easy way of living by any means. And so, of course, not every single person, every single time is going to have all of these barriers. But as we mentioned, every case is different. And, it is very likely that multiple of these barriers come into play, and it's going to make their road to a healthier life and tobacco treatment very difficult. And so now we're just gonna, I know getting close on time here, so we're just gonna be going through these rather quickly, going over some recommended evidence-based treatments for tobacco use and starting a quit journey. So with this in mind, if you have been to, some of our trainings in the past, or, you have found that these methods, they really don't change for any specific population, as these methods that we're going to go over, of course, evidence-based, which means they've been backed up by years and years of research to be effective. And so for the next few slides, we'll be discussing both medications and counseling practices that are evidence-based. So just getting started here. We just really when it comes to tobacco treatment, the best method is that combination therapy. So we have medications, so those over the counter or prescribed NRT medication, so the nicotine patch, gum, lozenge, inhaler, etc. Having those prescribed to these patients, clients, as well as counseling, so either motivational interviewing or cognitive behavioral therapy. Doing both of those at the same time is going to lead to the best outcome and the highest chance of success when it comes to becoming tobacco free. Um, and if I had more time, I would go over these more in depth. But due to the sake of time, we're just going to keep moving forward. But I do have for you all these 7 first-line tobacco treatment medications. So we have the nicotine patch, gum lozenge, the nicotine inhaler, the nicotine nasal spray, and then those prescribed medications, bupropion, Wellbutrin, or Zyban, and then varenicline or Chantix. And we also have those counseling strategies, as I mentioned. So motivational interviewing, ORS, which stands for open-ended questions, affirmations, reflections, and then summarization. So that's part of the motivational interviewing piece. And then with motivational interviewing as well, asking permission before sharing. And then we have cognitive behavioral therapy. So that essentially it's awareness of unhelpful thoughts, improving your mindfulness, problem solving, and coping strategy skills. So again, looking at both of these, it's going to be that combination. So using somewhat of a mix of what you can see on your screen there, it's going to give these individuals the best chance of success when it comes to tobacco treatment. And so, as I did mention, there are 7 first-line tobacco treatment medications. So as first-line medication, it's safe, effective, and FDA approved for a particular use. So 5 of these are nicotine replacement therapies, or NRT. And the 3 on the top can be obtained over the counter, so the patch, gum, and lozenge. The bottom 2, so the inhaler and nasal spray, do require a prescription. And then just touching on bupropion and varenicline really quickly here. Bupropion is an antidepressant, and it was discovered that when people used it for depression, they also had an easier time quitting smoking. So bupropion, Wellbutrin, and Zyban, those are essentially, they're all the same medication, just different names. And then we also have varenicline and Chantix that is strictly made for tobacco disorder treatment. And so the last thing I'm going to touch on today before I end is talking about some resources that are available for your clients. So starting with the Maine Quit link, which is, you can be found, the number is right there, 1-800-QUIT-NOW. For those of you who are not in Maine, each state and US territory has its own designated quit link, and it all has the same number as well. But essentially, what the main quit link can do, and again, within interest of time, I can't go too far into detail, but the main quit link can provide various services, a quit program, a quit plan, and you get access to online and over the phone sessions with your quit coaches, and you also get access to free NRT as well. And so very similar to the main quit link is the youth component, the My Life, My Quit program. And so this is essentially the youth component of the quit link, and it was developed with youth input as well. And what My Life, My Quit provides, it's free and confidential quit coaching sessions for those 13 to 17 who use tobacco products, including cigarettes, vapes, and chew. And then another program we have is the American Indian Commercial Tobacco Program. This program provides free, culturally tailored treatment to help quit tobacco. It includes phone and digital services that focus on commercial tobacco use, including cigarettes, vaping, and smokeless tobacco. People in this program will receive 10 coaching calls with dedicated native coaches, a customized quit plan, up to 12 weeks of NRT, and an online dashboard with materials, tools, and a supportive online community. And then just looking at some training opportunities and resources for all of you that joined today. Be sure to spend some time browsing our tobacco treatment material database within our website at ctimaine.org/resources. We have lots of free brochures, fact sheets, rack cards, and electronic resources to support tobacco prevention, treatment, and policy efforts. And then as well as the online Maine Prevention Store, which has digital and hard copy materials that you can order for free. There you can find free handouts, posters, stickers, and smoke-free area signs. And so that concludes the end of my webinar today. And I just want to again thank you all for being here. I hope you were all able to take something away, learn something new. But I know we have a few minutes left, so Alicia, I'll hand things back over to you to end things out.
Thank you so much, Derek. Thanks for all the information. There are a few questions in the chat. Um, let's see, I'll start with what is the range of tobacco use in the general population?
Um, so in terms of which products or is it more of a number based?
Well, it does not specify,
Okay.
just general.
Yeah, so when it comes to I would say the population of America as a whole, when it comes to tobacco product, I believe it's right around 1 in 3 individuals are using a tobacco product, on some level.
Thank you for that,
Yeah.
Derek. How exactly is race and ethnicity and gender a risk factor? I think you dug into this a bit. Is it because of targeted advertisements, zoning for our major POC neighborhoods, or would you say it was something else?
Yeah, it is a little bit of both of those, and um, so we have that targeted advertising, especially with the LGBTQ plus community. I know I mentioned that a little bit, but also it really is it's a big spectrum. So it's the increased likelihood of demographics as well. Lower socioeconomic status kind of comes into the mix there, but really um, with race as well, it's more of a culture thing, with you know parents, grandparents, and just the way of living a lot in these certain states and areas, smoking's more prevalent as well. So just that in itself is an increased risk factor. If you're seeing your parents, aunts, uncles, they're all smoking around you when you grow up, it can increase. And then with the sexual orientation one, it's been found as well that just that increased stress level that these individuals are facing, whether, it could be various reasons, but it is found that they do have higher stress levels overall. They have higher likelihood of anxiety or depression, and that itself is going to increase the risk factor as well. I hope that answered your question.
Thank you for that, Derek. Certainly good information. The access to healthcare and prevention certainly was something I was thinking of too as you were speaking. And just a comment, as I listen and learn, I feel hopeless in helping them get past the barriers. I can't imagine how they feel uphill, but the hope is that they get there.
Yeah,
Thank you for that,
absolutely.
Nancy. Yes. Um, and then also thanking for the presentation, learned so much. That's wonderful. Um, is the American Indian Tobacco Program nationwide or specific for each state to administer?
And so
And
I
if you,
believe, yeah, go ahead, Alicia.
I was just going to say, and if you don't know the answer to any of these, we can certainly come back with an email to follow up on any questions that we cannot answer.
Yeah, I'm not too positive on the answer for that one, so we can definitely get back to you on that. Good
Okay,
question, though. Thank you.
absolutely. How can we enhance health literacy overall?
Yeah, that one's challenging because again, it's really ingrained with people's cultures and families. And, um, you know, I would just really encourage I know it's easier said than done, but I think especially health and within itself needs to be talked to more within the school system, but that's kind of just more my personal opinion rather than what should actually be done. And so, talking about these things in these terms at a much younger age will just help people as a whole become more familiar with these issues and these topics. But really it comes down to, and with the involving world as well, you can find a lot more information online. The access is easier. It's not how it used to be where everything was, before, pre-online days. It's more of, textbooks and things. And so we can hope that with the increased access to online, the health literacy will improve, but there's also that possibility of those untrusted sources. So it really becomes an issue of if people are finding the right information as well. So the internet's definitely a double-edged sword, but it can very well increase health literacy as a whole.
Thank you for that, Derek.
Yeah.
Certainly, finding those trusted sources is really important. There is a recorded health literacy webinar on our CTI website. Just wanted to bring that forward if you want to go in and check that out. Um, More of a statement. Why do you, or question for you, Derek, why do you think they even allow tobacco use at all in correctional facilities?
Yeah, and so a lot of that really ties down to different states and their policies and procedures. So I'm not entirely sure on the answer of why certain states allow, some states just fully allow it. Some of it's kind of a loose ended where people kind of get away with it, and some states are more strict, can even go down from county to county within each state. And so I'm not sure on exactly why it is allowed. I don't believe it should because, in the general public, even going to stores, restaurants, some states even, some states have tighter laws and policies, but most states you cannot smoke indoors within these general public areas. With these facilities, of course, being what I would what I would consider a public area where there's other people around you, you're indoors, that exposure to second, third hand smoke, of course, tie in why it's being allowed. I'm not so sure. But again, it really ties down to the states or the county's policies and procedures.
Thank you, Derek. Next question is, how is tobacco intervention, introduced to to the juvenile system? Is parental approval needed? Is a parent asked to join if they use tobacco too?
I'm not sure on the answer to that one. I know with certain tobacco issues or programs when it comes to the youth, usually some sort of parental notification is at least required or permission, but I don't want to say 100%. I'm not sure on that one. So we'll definitely have to get back to you on that.
Okay. Thank you, Derek. Do you, this is more of a funding question. Are you aware of any current funding going toward the justice involved communities?
I'm not
It,
I'm not sure when it comes to, of course, all of them as a whole. My hope is that, of course, because it's really tricky with different counties, different states again. My hope is that there are some, but I'm not sure in terms of the justice system as a whole.
okay. Thank you. Another question with the justice involved population, is group therapy the best practice over individual CBT or MI?
It's tricky because within this population, I find, especially when they are incarcerated, when they're serving their time one-on-one, it can be just difficult to find time in the day for both the instructors and, these individuals are on a very scheduled day. So it's more than likely that all of all of these incarcerated individuals, they follow the same schedule. And so group just tends to be easier because they all have that time throughout the day. But I would say both MI and CBT can be effective in a group setting.
Okay, great. Thank you for that. And just a comment that talking with kids at an early age is key to prevention. I've been presenting to students at the third and fourth grade level for years, and they are very capable of comprehending the risks of tobacco and e-cigarette use. So I
Nice.
appreciate that comment, Mark.
Yeah, absolutely.
Um, and it is 1 o'clock, so I will wrap us up, but we certainly will get back to questions via a post-webinar email, any questions that we were unable to respond to. So thank you again, Derek, for your time, for all of the information during the webinar today. Once again, the webinar was recorded. It will be posted to our website. Again, in order to claim CMEs, you must have a profile in Cloud CME, and instructions can be found in the post-webinar email that will be coming out later. For those that are collecting CHES credit, it will be sent to NCHEC after the event. Only those who registered for the webinar, connected via the Zoom link, and attended the full session will be able to receive CMEs and CHES credits. We're required to verify those who attended. You will also receive this information and a copy of Derek's slide deck in a post-webinar email. And additionally, an evaluation will appear up here on your screen once the webinar is closed. Please take the time to provide your feedback. And if you ever have any follow-up questions, please feel free to contact us. And we thank you for your participation and take care.